And welcome to the RHIT exam review. This is Dr. Campbell, and for this session, we're going to focus on the revenue cycle. The domain of the revenue cycle has 11 tasks that you should be able to perform on the RHIT exam. So let's talk about those tasks in more detail. Number one, be able to communicate with providers to discuss documentation deficiencies. So one of the things that's very, very important, and you've heard this discussed in other domain reviews, is that accurate coding is going to be based on physician documentation. You want to keep in mind that as the HIM professionals, we are the expert in the coding guidelines, the coding rules, and resources. The physician, their job is to take care of the patients. So sometimes there are situations where the documentation is not complete, it is not timely, it is not clear as to what the provider is trying to communicate. And so in some instances, we have to issue the physician a query. It's a question. You have been exposed to the physician query process in previous review sessions, so I won't talk about what a query is, but I want to just review what should be contained within a query. Obviously, you want to reference the patient's name or account number or medical record number. You want to identify when they were admitted, what date of service you're talking about in particular, and then you want to identify the date that you're actually submitting the query. The reason why this is important is that we do track queries for purposes of our metrics in terms of the query process. So it's very important for us to identify when queries were actually initiated and who was the initiator of the query. When we query the provider, we're going to take the information from their medical record and we're going to state the issue in the form of a question. So we could say something like, Dr. Smith, clinical indicators from the chart were the history and physical states urosepsis. The lab report states a WBC of 14.4. In the ED, the patient reports the patient had a fever of 102. Is there a diagnosis that supports the data that has been provided? And that's just an example of how we could query the provider. As we have moved into an era where documentation is going to play a huge role in the quality of care, the perceived quality of care, organizations are implementing clinical documentation improvement programs. So the second task that you should know under the revenue cycle is to be able to participate in the CDI program to ensure proper documentation of health records. On the AHIMA website, you will be able to locate a practice brief or a toolkit, to be exact, a toolkit that says Clinical Documentation Toolkit. And I would highly recommend that you download this toolkit because it's going to give you all of the ins and outs of clinical documentation improvement programs. So let's just talk a little bit about them. So clinical documentation improvement programs is basically where we are improving the quality of the clinical documentation. The individuals that are performing this function can really fall into two categories. They're either HIM professionals or they're registered nurses, or it could be a combination of the two. Quite naturally, the health information management professionals bring to the table our coding knowledge, our knowledge of the guidelines and the systems and the resources. We also have clinical knowledge, and then the RNs quite naturally have a solid clinical background. So the combination of those two disciplines really present a win-win for an organization. So what skills are required? You definitely have to understand the clinical disease process. In the query, that I showed you a few minutes ago, you have to know what information to pull out the medical record in order to query the provider. So that's the reason why in your programs you have to take the medical terminology, the anatomy, the disease process, and pharmacology. It's because you have to understand that not only to code the record, but if you're going to function as a clinical documentation improvement specialist, that's a must-have skills. Also, the ability to communicate effectively. In a lot of situations, you're face-to-face, elbow-to-elbow with the provider. So you have to be able to not only communicate with them in a written format when you're submitting the query, but also verbally. It could be that you don't have an opportunity to query the physician in writing, that you happen to see them on the unit, they're next to the patient's room, and you have identified that a query is needed, and you can go over to them and discuss the case with them and ask them to provide an amendment to the record. Because you are working with physicians who tend to have very strong personalities, it's important that you are confident in your skills, in your role, and really your objective for carrying out the clinical documentation improvement process. One of the things about the CDI programs is that it's very important to have provider involvement, provider buy-in. What a lot of organizations will do is to identify a physician champion. And the reason we need the physician champion is that sometimes we encounter providers who unfortunately don't want to play fair with us as HIM professionals or even the nurses, and they'll say, well, you're not a doctor. And so sometimes we have to have the peer go and talk to their colleague and explain what the goal is behind the questions that are being asked. So we have to emphasize that we're not questioning their clinical judgment, but from a documentation review perspective, there are some gaps, and we want to be able to close those gaps. And so it's all about building the team. It's all about creating the credibility of the CDI staff. And ultimately, once you have the providers buy-in, we can improve documentation. We can help them build a better physician profile, one that reflects the severity of illness that they're actually treating. From time to time, we do have to educate our providers. So let me give you an example. We could notice that we are sending in lots of queries because the cardiology group, for example, keeps writing down heart failure, and that's all that they write. However, upon further review of the record, we notice clinical indicators such as an echocardiogram with an injection fracture that is showing that the patient perhaps has more than heart failure. The patient could have diastolic heart failure. They could have systolic heart failure. And as you know, from a coding perspective, there are codes for heart failure. There are codes for congestive heart failure. There are codes for systolic, diastolic, and systolic. So our goal is to ensure that our diagnoses truly reflect what the patient has and what they're being treated for. So from time to time, we often have to provide education to our providers. We want to ensure that we choose the best method for that particular group of providers. It could be that the providers have a department meeting, and we go to that department and we do a 10-minute presentation on documentation of heart failure. And one of the things I like to do when I meet with providers is just say, hey, providers, you want us to stop sending you those queries on heart failure? And then, of course, they will say, absolutely, yes, we do. So then we'll say, okay, well, let's collaborate on how we can decrease the queries that you're receiving on heart failure. So let's talk about heart failure. Get them to talk to you about what heart failure is from a clinical perspective, the diagnostic tests that they perform, and how those diagnostic tests help them determine what type of heart failure the patient has. That's a perfect lead-in for you to then say, okay, well, from a coding perspective, here are the heart failure codes, and as you'll notice, they're divided based upon the type of heart failure the patient actually has. So when we know more information about the heart failure, it's critical that our documentation and our codes demonstrate the exact type of heart failure. So how you present the information really is organization specific. It can be individual. It can be a group presentation. It can be a newsletter. And one of the things that we found that's very, very effective is to show our physicians from a financial perspective how much the hospital has lost because of the use of a generic heart failure code. So one of the things you can do is show them the 3 tiers of the MSDRG and how, a plain diagnosis of heart failure can result in this DRG. However, if it's congestive heart failure or if it's diastolic systolic, it results in this MSDRG. And why that's important to the provider is that providers, as you guys should know, and we'll talk about this in a few minutes here, but providers are not paid based on the MSDRG. Providers are paid based on the resource-based relative value scale, the RVRVS. So the MSDRG really is not important to them, but it's important in terms of the hospital being able to be reimbursed for the services that we've provided. And so lastly, regarding CDI programs, we want to ensure that we encourage questions and answers. You can always ask for questions ahead of time so that you can have the answer available, whether you need to research coding clinic or other resources to make sure when you meet with the physicians that you have everything organized and ready to go. Keep in mind that the doctor's time is very, very valuable, so you want to ensure that you are ready with clear and concise information. And if it's something that you don't know, just say, I don't know, I will need to research, and I will follow back up with you. Okay? That goes a long way as opposed to giving incorrect information that you then have to retract later. Task number 3, collaborate with other departments on monitoring unbilled accounts, monitoring our accounts receivable. So remember, accounts receivable are monies that are owed to the organization. So monitoring these accounts receivable does take a collaborative approach. It does take a multidisciplinary approach. Quite frequently, the hospital CFO is looking at a report called Discharge, Not Final Billed. We call it the DNFB. Again, discharge, but not final billed. And what this means is that we have seen the patient, we've provided care to the patient has been discharged from our hospital. However, a final bill has not been submitted to the insurance company. There are many reasons why the claim can be on that report. It could be that it's missing information from a clinical department. It could be that it's missing insurance information. It could be that it needs to be coded. There could be a backlog in coding. It could be that there's a query that's out on that particular hospital stay, because once the query is submitted to the provider, that chart basically goes on hold. And that's why it's important for us as HIM professionals to ensure that we understand AHIMA's query process, guidance that they've provided to us, and that our organizations have written policies and procedures related to the query process. So it's a multidisciplinary approach because it's not just HIM that's responsible for the accounts that are on this report, but we want to work together to ensure that we keep the dollar amount of this report as low as possible, that we have processes in place for working this report and resolving the issues in a timely manner. Task number 4, provide ongoing education to healthcare providers. So one of the things that's very, very important is alerting our clinical staff to changes that are going to be coming down the pipeline. So for example, usually around somewhere between February and April of every year, the ICD-10 Coordination and Maintenance Committee gets together to determine what the new codes are going to be for October. And so if we stay abreast of those changes, we can begin to educate our providers on things that they're going to need to change from a documentation perspective, kind of getting them ready for those changes before they actually happen. So there are some examples of things that we can cover in training sessions, and I'll just cover a few. If there is a change to any of the official coding references, such as the AMA CPT Assistant or the AHA Coding Clinic, we want to obviously, as a department, review those articles on a quarterly basis. And if there is something that's going to impact coding, that's directly tied to documentation, we want to work with our physicians to kind of clean up the documentation so that we are ensuring that our documentation supports coding. If there are any changes to guidelines, we want to make sure that perhaps our query forms are updated and that we're educating our providers on, again, specific documentation needs that have to be met. We also want to ensure that if there are changes in the prospective payment system, changes in reimbursement, that we are notifying the physicians as well. I can tell you that cardiology is a specialty that often is experiencing a decrease in reimbursement. So it's always a good idea to give the providers a heads up on, that, hey, next year we're going to be reimbursed lower for certain procedures. And again, we want to emphasize how important it is that our documentation is 100% complete and supports the care that's being provided. So still thinking about, ongoing education. Here are some examples of documentation problems that we commonly see. So we already know we have the query process in place because of inconsistent documentation. One of the things that's the bane of our existence is incomplete documentation. We oftentimes have situations where the physicians are saying, for example, the patient has a history of breast cancer, but they had chemotherapy this morning. So we know from a coding perspective, according to the guidelines, that the patient is being treated for that particular therapy. We want to ensure that the patient's diagnosis is listed as a current condition as opposed to a history of. Task number 5 for revenue cycle is to identify fraud and abuse. So there are several laws and regulations that have been enacted to combat healthcare fraud and abuse. It's very important that you know what they are. So I've listed here some of the most common ones. So let's just talk about a few. On an annual basis, the Office of Inspector General publishes a work plan. The work plan identifies by Medicare A, Part B, Part C, Part D. It identifies what they're going to be looking at. As an organization, it's in our best interest to identify those areas and self-audit to ensure that if we were to get audited for that service by the OIG, that our documentation supports coding. The recovery audit contractors, those are the organizations that are looking at primarily inpatient hospital claims, specifically related to DRGs, but they can also look at physician claims, outpatient hospital claims as well. And so really, if I had to sum up all of these efforts, one of the things that kind of stands out for me is that the government, CMS, has realized that they are paying for claims, paying for services to Medicare beneficiaries when we don't have the documentation to support that we actually provided that care or we provided that level of care. And so CMS has decided if your documentation does not support the level of care and we've paid you for that service, we want those monies back. So you'll notice every year there is some program that the government is initiating to combat healthcare fraud, and the fines are getting stiffer and stiffer as the years go on. Number 6, assists with appeal letters in response to claim denials. So this diagram here is actually representative of the claims denial appeal process for CMS. And so the very first thing that happens if we want to appeal a claim that has been denied, we're going to send it to our initially to our Medicare administrative contractor. We call it the MAC. And so let's say they've denied the claim. We appeal it, with supporting documentation, and they still say, no, we're not going to pay for that claim. Then the next step would be reconsideration by a qualified independent contractor. Okay, if they say, no, we agree with the Medicare administrative contractor, the appeal process can continue all the way up to a judicial review. Now, the one thing that we want to ensure in terms of our appeals process is that we have the documentation to support why we should have been paid for the service. Oftentimes, we can attach a coding clinic article that states, according to Coding Clinic 2008, fourth quarter, we need to code this service this particular way. We have supporting documentation, and we request that we be paid for the services as rendered and documented. All right, so some additional information regarding assists with appeal letters in response to claim denials. Again, very, very important that we show why our service is valid, why we should be paid. One thing to note is that the appeal should be in writing, and unfortunately, every payer outside of Medicare has their own policy and process for appeals. So you want to ensure in a real world perspective that you understand their process. If we're talking about on the RHIT exam, knowing the CMS policy is universal, so that's the extent that I would recommend that you know. Number 7, monitor claims denials, overpayments to identify the potential revenue impact. Another report that is going to be on our CFO's desk. Notice I keep mentioning the CFO, and quite naturally the CFO is responsible for ensuring that the hospital can pay its bills, right? And its bills include services that have been rendered by hospital staff, as well as the lights and the equipment and supplies. And so they're constantly looking at all of these reports. And so it is very important that when we do receive a denial, that we really try to figure out why we're having this denial. Is it a particular financial class? Is it Medicaid, for example, that's denying a particular service? Is it a particular MSDRG that's being denied? Is it a provider that's getting denied because perhaps the provider's not credentialed with the insurance company? It could be that from a data service perspective, that we submitted the claim beyond the timely filing deadline that's been established by that payer. So we want to monitor these claims denials, but also kind of put them into buckets and really evaluate why they're happening. And if there's something that we need to resolve from a department, that we resolve those issues so we can keep those denials down. Because again, remember, the hospital is providing a service, and we want to make sure that we reimburse for the services. And the CFO, of course, wants to make sure if he's paying salaries that he has money to pay out those salaries. Number 8, prioritize the work according to accounts receivable and patient type. So what does that mean? Well, think about it. If you have $1 million claim, that's definitely a claim that you want to work on. Organizations have a variety of ways in which they prioritize the work. I've listed a couple of things here for you on the slide, such as looking at how old the account is. That's known as the age of the account. So um, when we are prioritizing the work, every organization has a policy for how they do it, but typically age of the account is very important. So a few minutes ago, I mentioned timely filing. So in some instances, the insurance company is not going to pay the claim because we submitted it too late. So it's very, very important, going back to that discharge but not final billed report, that we monitor those accounts and make sure that we're getting the claims in for under that designated time. In some instances, organizations can say, for example, there's a query out and it's been 30 days and that query has not been responded to. In some instances, we submit the claim as is. So maybe we had an opportunity to have a higher weighted MSDRG, and because there was no response to the query, we have to submit a lower weighted MSDRG. Number 9, distribute the work according to accounts receivable patient type. So again, more examples. I already talked about the ages. I already talked about, looking at the discharge not final billed report. So really when you look at number 8 and number 9, prioritizing, distributing the work, we have to identify which of our team members are going to be working those specific accounts. And usually organizations will have various ways that they group the work, but it could be that HIM staff rotates, as a part of your duties as a coder. You have 1 day per week that you're going to be working the report and cleaning up the accounts. So it just really depends on the particular organization. Number 10, maintain the Chargemaster. So we know all about the Chargemaster. We learned about this in coding, but the Chargemaster is really this electronic file where different departments are going to be entering their charges at the point of service. So for example, a patient goes to the radiology department and they receive a 2-view chest x-ray. The radiology department is going to be responsible for entering that charge. And when you think about it, it actually makes sense. A 2-view chest x-ray, it's a CPT code. They probably do hundreds of them a day. You don't necessarily need a coder to identify 500 2-view chest x-ray codes. It is more beneficial for the organization for us to look at things, inpatient records, where we're coding coronary artery bypass grafts, where we're looking at a $30,000 service as opposed to an EKG or a chest x-ray, which could represent a $100 service. So one thing to remember regarding the Chargemaster is that it is known as hard coding because it is hard coded into the system, whereas the coding that is performed by a coder is known as soft coding. It is very important that the Chargemaster be maintained and updated on an annual basis. Reason being, our codes are updated on an annual basis. If we have claims denials, we want to find out if it's due to the Chargemaster. It could be, something that was inputted into the system incorrectly, and now as a result, we are seeing denial. So it's something that has to be routinely checked, and we're not talking about once a year, but throughout the year. Every organization has a different approach. They can have a Chargemaster team. Depending on the size of the hospital, they can have a Chargemaster person that's involved in the Chargemaster. But it's very important that we utilize a multidisciplinary approach, because let's say we identify issues with charges from radiology. We'll want to work with radiology to resolve the issues. It could be that they're incorrectly selecting something. It could be a variety of reasons, but again, we always want to work collaboratively with other departments. So what does a charge master actually look like? You could, if we were to extract a file into Excel, imagine an Excel spreadsheet with several columns. The first column being the department number, the second column being the charge number. The charge number is typically what the department is using to charge for the service. And then next to the charge number is a description. Of course, because we're going to be submitting the HCPCS code to the insurance company, the Chargemaster also is connecting it to the actual code from the coding manual. So when I mention maintaining the Chargemaster, we want to make sure that all of the codes are inputted correctly. If there is a service that must go out with a particular modifier, we want to make sure that that is hard coded into the Chargemaster. Also on this file, you're going to have a quantity or a dose column. So think about medications where there's a quantity of one. Think about supplies that are used during the hospital stays that can result in more than one quantity of that service being provided to the patient. Each of these services are going to be attached to a revenue code. The revenue code is really going to identify that particular area. So for example, pharmacy has a revenue code. Radiology has revenue codes. And I say codes because there are codes for, like your x-rays, your CT scans versus your ultrasounds, etc. Then the charge, not what the hospital gets paid, but the charge for that service. And then the charge status. Now, organizations will have different names for these columns with the same end result. One column that I can recall being on the Chargemaster is when that code was active, when that code was inactive. And the reason why that would be important is that, as you guys know, codes are deleted. But we don't want to delete them from the Chargemaster because we can have a claim that is pending, and we want to make sure that that claim, that code is still in our Chargemaster. Also, we don't delete them because of purposes of collecting historical data. So as I stated, with the Chargemaster, we're talking about hard coding. At the point of service, those departments are submitting the charge codes in the system. And when you think about it, it is in their best interest to ensure that they are capturing all the services that their department is providing. When you think about it, radiology department, if you do 5,000 services in a week, you want to ensure that those 5,000 services are captured. Why? The hospital bringing in money for the services that are provided allows the CFO to pay our salaries for that department. So if the CFO notices, wait a minute, we have seen a decrease in revenue for the radiology department, we need to look at staffing. Do we need to let go one of the radiology technicians? We're going to look at our staffing because, again, the hospital has to make money in order to pay their bills. Number 11, ensure physicians are credentialed with different payers for reimbursement. This is very, very important because if the provider is not credentialed, unfortunately, we may not be paid. So during the credentialing process, there are several documents and processes that are involved. So I'll just highlight a few. We definitely want to ensure that we have a copy of the physician's current license. If the provider is going to be providing their own malpractice insurance, we need to have a copy of that certificate. As I'm sure you guys have heard this term before, but we must always query the National Practitioner Data Bank because we want to make sure that that provider has not been disciplined in any way that can adversely affect our hospital. The credentialing process will typically occur at the time of hire, and then depending on the organizational structure, um, the hospital will re-credential that provider. So it can be 2 years, it can be 3 years. Take a look at your sales text because she will give you more about the credentialing process. But one thing to note is that if the provider is not credentialed, that can result in the hospital not getting paid. So those were 11 tasks that you needed to know. So let's look at some knowledge areas that you need to know as it relates to the revenue cycle. You guys have an excellent textbook for the revenue cycle before taking the RHIT exam. I would highly recommend that you reread that textbook because it really does um, lay a great foundation in terms of the revenue cycle and what you need to know for the exam. So looking at some knowledge areas that you need to know, let's talk about medical necessity. There are certain services that Medicare has issued either a local coverage determination or a national coverage determination. And those determinations really identify the particular service, the documentation requirements, and from a medical necessity perspective, which codes support the medical necessity of that service. Now, one thing that we don't want to do, we don't want to use this document to code from. We have to code based on the documentation. So what I mean by that is we cannot just pick up an LCD and say, okay, in order for this service to be paid, we got to use one of these diagnoses on this list. The patient has to actually have that condition. Another area that you need to know as it relates to the revenue cycle is the advanced beneficiary notice, which we refer to as the ABN. The advanced beneficiary notice ultimately is a document that we provide to the patient in situations where we believe that Medicare is not going to reimburse us for the service. And if Medicare is not going to reimburse us for the service, but the patient still wants to have the service rendered to them, this advanced beneficiary notice informs the patient of just that. You know, if you want to have this service, you will need to sign here. This is how much it's going to potentially cost. And then if the patient says that they still want that service, and we have this signed form, we go ahead and submit the claim. There are Medicare specific modifiers that you'll want to know about. These modifiers basically say, hey, Medicare, we have the advanced beneficiary notice on file. And so if you don't pay for this service, we're going to bill the patient. Now, this can also work in the reverse. We know that Medicare is not going to pay for the service, and we don't issue the patient the ABN. And so we don't have these modifiers attached to that particular service on the claim form. Then guess what? No ABN, you can't bill the patient. So it not only protects the patient in knowing what Medicare is going to cover, but it also, lets them know that, you acknowledge that you want this service, and we list the CPT code, we list how much we charge for that service, and then the patient is going to acknowledge that, yes, I want this service. Okay, two other concepts that you need to be aware of, and I know you've heard these before, and it's the intensity of service and the severity of illness criteria. So this is typically something that is explored when we are thinking about admitting a patient to the hospital. And I want you to consider this scenario. Let's say that you have a patient that has asthma, And the patient is in the emergency room today and has been seen by the emergency room physician. They have not been seen by their private doctor. The asthma problem just occurred because of the change in the weather. The emergency room provider is able to safely stabilize the patient and believes that the patient can be safely treated at home on oral steroids, on oral antibiotics. There's no need to admit this patient. Of course, quite naturally, we tell the patient that, if the symptoms get better or worse, to come back to the emergency room. Okay, so the severity of that illness didn't warrant a hospital inpatient stay. The services that the patient needed, such as the oral antibiotics, the oral steroids, that patient could safely take those at home. Okay, let's see a different scenario. Let's say that the patient has asthma again, and the patient has been treated for the last 30 days as an outpatient. They've seen their private physician. The physician has had them on a course of antibiotics. The physician has had them on a course of steroids. And 30 days later, the patient is not getting any better. So the patient presents to the emergency department, and we give them a couple of breathing treatments, but the asthma is still not getting better. And the physician decides, in order to resolve this asthma, we need to give the patient IV antibiotics. We need to give the patient IV steroids. And so in this instance, the intensity of the service has been met. The severity of the illness, that criteria has been met. So that's an example of what we mean by intensity of service, severity of illness. Hospitals have software that they use, kind of like a decision tree that helps them, kind of like a yes, no, has the patient failed outpatient treatment? Well, if they failed outpatient treatment, then obviously the next step would be more intense services. Okay, the other things that you need to know on the RHIT exam from a revenue cycle perspective are the different reimbursement methodologies. Now, I'm not going to go over all of these, but you will have a copy of the slides uploaded at the end. But what you'll want to notice here is that I have them divided based upon acute care settings, so your inpatient hospital settings, as well as ambulatory settings, and then post-acute care settings. So for purposes of the RHIT exam, make sure that you are familiar with all of these different reimbursement methodologies. So on this slide here, as well as this particular slide here, I feel pretty confident that you guys are familiar with things like MSDRGs, because that was covered in your coding classes, the APCs, the RBRVS, but just ensure that you're familiar with these different reimbursement methodologies. Also, to kind of tie this together, also want you to think about, for these different reimbursement methodologies, the data sets, make the connection between the reimbursement methodology and the data set. So for example, inpatient hospital care, we're reimbursed based on the MSDRG. Well, the data set that ties into that is the Uniform Hospital Discharge Data Set. So make sure that you understand those data sets and tie them into the reimbursement methodologies. Okay, you also want to know about the different insurance plans. So you want to make sure that you know the government payers, such as your Medicare and Medicaid. Know the parts of Medicare, Part A, B, C, and D. No more than it's just A, B, C, and D, but also know what A is, what B is. How does it compare to Part C and D? Okay. The other thing, the non-government programs, such as managed care programs, know the differences between those programs. Also know about a provider's participation status, participating provider versus a non-participating provider. Know what the limiting charge is That means how much a non-participating provider can charge. Remember the term capitation, which is tied to our HMO products. So pay per performance, fee for service. Know the differences in these terminologies. And then lastly, you want to ensure that you know the difference between the UB04 claim form versus the CMS 1500 claim form. The UB04 claim form is used to reimburse for facility services, whereas the CMS 1500 is utilized for the provider, no matter where he or she is providing care. You also want to know about the explanation of benefits. That's the document that the patient receives in the mail from the insurance company that explains how the services were paid on their behalf. Likewise, the organization is going to receive a remittance advice attached to a check, or the check is going to be a direct deposit, and that shows the hospital, typically with more than one patient on the advice, how the claims were paid. And we use the remittance advice to enter those payments onto the patient's account. And then coordination of benefits. This is when the patient has more than one insurance, how much those insurances are going to pay. It's not going to equal more than 100%. So remember, sometimes patients have a primary and a secondary insurance, and then they also have a third insurance, which is referred to as a tertiary insurance. Also, remember here, this is where the birthday rule comes into play. Okay, so now that we've done a review, we're going to look at some questions to check your understanding of the material that we have covered on today. Okay, our first question. In healthcare settings, the record of the cash the facility will receive for the services it has been provided is known as which of the following terms? Is it A, dollars billed, B, aging of accounts, C, accounts receivable, or D, cash balance? And the answer is C, accounts receivable. Healthcare facilities should think of the collection process as part of the complete billing process and should educate staff to the fact that not all money billed is it A, pending, B, charged, C, reimbursable, or D, collected? And the answer is D, collected. Everything that we build will not always get paid. Aging of accounts, our next question, is the practice of counting the days, generally in increments, from the time a bill has been sent to the payer to the current day. Is the answer A, 7 day, B, 14 days, C, 30 days, or D, 90 days? So we're talking about the aging of the accounts and the increments. And so the correct answer is C, for 30 days. Next question. The amount of money owed a healthcare facility when claims are pending is called A, dollars in accounts receivable, B, bad debt, C, the write-off amount, or D, delayed revenue. So here, the correct answer is A, dollars in accounts receivable. This is because this is money that is owed to the healthcare facility. Next question. Patients with all of the following conditions are appropriate for LTACs. Except, watch out when they say except. A, acute myocardial infarction. B, chronic tuberculosis. C, sequela of head trauma. Or D, ventilator-dependent emphysema. So remember earlier I mentioned knowing the different prospective payment systems. This is one of those questions that you have to understand the prospective payment system in order to answer the question. So LTAC is long-term care. So the correct answer is acute myocardial infarction, because the acute myocardial infarction would be treated in an acute care facility and not in a long-term care facility, because again, it's the acute condition. And the question said the LTACs are appropriate for all of the following except. Next question. To meet the definition of an intermediate rehab facility, facilities must have an inpatient population with at least a specified percentage of patients with certain conditions. Which of the following conditions is counted in this definition? Is it A, brain injury, B, chronic myelogenous leukemia, C, acute myocardial infarction, or D, cancer? So an intermediate rehab facility, the answer would be A for brain injury. Next question. All of the following elements are used to calculate a Medicare payment under the Resource-Based Relative Value Scale, which is the RBRVS, except A, work value, B, malpractice expenses, C, extent of the physical exam, or D, practice expenses. The correct answer is C, because the work, the malpractice, and the practice expense are used to calculate. The question asks, except. Next question. Which of the following statements is true about APCs? Again, you have to know the terminology. So APC, ambulatory patient classification. A, APCs are based solely on the principal diagnoses. B, ICD-10 PCS procedure codes are used to group patients. C, severity of illness is taken into consideration when grouping APCs. And D, APCs are based on the CPT or the HCPCS code reported. So again, very important to know the differences. Well, one thing that you should immediately notice, principal diagnoses. Principal diagnoses is related to the MSDRG, right? APC is your ambulatory patient classification. So the statement that is actually true is going to be D. They're based on the CPT or HCPCS code reported. Next up, what is the average of the sum of relative weights of all patients treated during a specified time period? You should remember this from your statistics class. And the answer, let's look at our choices first. So A, case mix index, B, outlier pool, C, share, or D, mean qualifier. And so for this question, the correct answer is A, case mix index, where you add up relative weights for patients over a particular time period, and then you divide them by those patients, and that gives you your case mix index. Next question. What is Medicare's term for a facility with a high percentage of low-income patients? Is it A, disproportionate share hospital, B, financial hardship hospital, C, income payment facility, or D, underserved facility? And the correct answer is A, disproportionate share hospital. Next question. What is the name of the entity that pays Medicare Part A claims? Is it A, Blue Cross Blue Shield? Is it B, the Medicare Administrative Contractor? Is it C, Blue Cross? Is it D, the Medicare Code Editor? Now, be careful on the exam. The question says, what is the name of the entity? Well, guess what? Medicare Code Editor is not an entity. Correct answer here is going to be B for Medicare Administrative Contractor. The next question, why did Congress pass the HMO Act of 1973? Is it A, to encourage the delivery of affordable quality health care? Is it B, to increase the number of physicians in primary care? Is it C, to deter the privatization of Blue Cross plans? Or is it D, to standardize the cost of health care across the nation? The answer is A, to encourage the delivery of affordable quality health care. Next question. All of the following sets represent criteria for medical necessity and utilization review, except, we just talked about this. A, intensity of service, severity of illness, and discharge screens. B, appropriateness evaluation protocol. C, Milliman, Interqual, and Robertson guidelines. Or D, Federal Register Index and ratings. So all of the following sets represent criteria for medical necessity, except, and it would be the Federal Register. The Federal Register does not represent a set for the medical necessity. Next question. What is the term for a managed care organization that serves Medicare beneficiaries? Is it A, Medicare Advantage, B, Social Foundation, C, Part A, or D, exclusive provider organization? So again, you got to know about Medicare. And the answer here is A, Medicare Advantage. Next question. Which part of the Medicare program was created under the Medicare Modernization Act of 2003? A, Part A, B, Part B, C, Part C, or D, Part D? Again, you have to know more than Medicare has 4 parts. You need to know what those 4 parts are, when they were implemented, and this particular answer is D for Medicare Part D. This program, formerly CHAMPUS, provides coverage for the dependents of active members of the armed forces. Is it A, TRICARE, B, CHAMP VA, C, Indian Health Service, or D, Workers' Compensation? And because it is the active members, the answer is A, TRICARE. The Medicare program is divided into A, 2 parts, B, 3 parts, C, 4 parts, or D, 5 parts, and we know the answer is C, 4 parts. Next question. In regards to health insurance, the percentage that the guarantor pays is called the A, coinsurance, B, copayment, C, deductible, or D, contractual disallowance. And the correct answer is A, coinsurance. Which of the following services has the highest likelihood of being a covered service? A, pre-existing condition, B, experimental, C, medically necessary, or D, cosmetic? And the answer is C, medically necessary. Next question. In which type of reimbursement methodology do health insurance companies reimburse providers after the costs have been incurred? Is it A, retrospective payment, B, block grant, C, prospective payment, or D, global payment? And the correct answer is A for retrospective payment. The notice from the healthcare insurance plan used the abbreviation PMPM. How should the insurance analyst interpret this abbreviation? Make sure that you know the abbreviations that are used in our industry. Is it A, per member per month, B, premium method post modification, C, program mix per medical provider, or D, period method payment model? And the answer is A, per member per month. This is related to HMOs and the concept of capitation. Next question. The practice of undercoding can affect a hospital's MSDRG case mix in which of the following ways? A, makes it lower than warranted by the actual service resource intensity of the facility. B, makes it higher than warranted by the actual service resource intensity of the facility. C, does not affect the hospital's MSDRG case mix. Or D, coding has nothing to do with the hospital's MSDRG case mix. And the correct answer in this case would be A. Next question. The policies and procedures section of a coding compliance plan should include A, physician query process, B, unbundling, C, assignment of discharge destination codes, or D, all of the above. Correct answer is D. All of the above should be included in the policy. Next question. The unique number that identifies each service or supply in the CDM, that's the Chargemaster, and links each item to a particular department is known as A, revenue code, B, general ledger key, C, charge code, or D, item description. And the correct answer is C for charge code. Next question, and our last question. Which of the following is associated with the Medicare SNF prospective payment system? SNF is Skilled Nursing Facility. Again, must know the abbreviations used in our industry. Is it A, CMG, B, DRG, C, RBRVS, or D, RUG3? And the correct answer is D for the RUG. Well, that wraps up another session on the RHIT exam review. I truly hope that this session was beneficial to you, that it was a great review. I am going to upload the PowerPoint slides for you, so you'll have them now in the files box that's listed there. You can download them and save them to your computer and review. Well, good luck on the RHIT exam and have a great day.